and welcome, Doctor. My name is Eshika Paruchuri, and I'm a sophomore at Woodbridge Academy Magnet School. I appreciate you joining me in this initiative, and my priority is to educate adolescents globally, leading them to build healthier lifestyles by collaborating with experienced doctors from various specializations around the world. Welcome to the Healthy Teens podcast. I hope you are keeping well. This month, I'm joined by Dr. Edward Soffen, who specializes in radiation oncology. He has expertise in treating various types of cancer using different forms of radiation to detect and kill malignant cells. And for this episode, we'll be focusing on multiple issues related to the prevention of cancer and cancer-related diseases, as well as the steps that can be taken to have a healthy body and lifestyle. And now, Dr. Soffen, can you give us a little background regarding your experience in this field?
Sure. First of all, I want to say welcome to everyone and to you, and thank you for starting this initiative. I think it's a fantastic idea. Wish we had this kind of program when I was in high school. Anyway, my name is Dr. Edward Soffen. I'm a radiation oncologist. That means I use ionizing radiation to treat and kill cancer cells. Most of what I do is with patients who have malignancies. We do treat some benign conditions as well. I've been practicing for 33 years in central New Jersey. I went to Johns Hopkins undergraduate. I went to Temple Medical School, and I did my residency at University of Pennsylvania. And I've been working in central New Jersey at several hospitals and at a proton center that we have, and we can talk a little bit later about protons and x-rays, those types of radiation. I treat all types of malignancies. I treat young and old, men and women. I treat people with the intent to cure them. We also treat patients who don't have curable cancer but are having symptoms, and we want to palliate. We want to help get rid of their symptoms. So it's either curative or palliative type of treatment. I treat all forms of cancer from the head to the toe. The most common cancers that we see in the United States are breast cancer in women, prostate cancer in men, lung cancer in both, and then there are a number of other cancers, colorectal cancer, brain tumors, pancreatic cancers, and a lot of skin cancers.
Very interesting. Okay, so now that we have a briefing about, where you come from and your experience in this field, let's get into the questions. So, what is radiation oncology, and what are its primary goals in treating cancer?
Well, radiation oncology is harnessing the energy of ionizing radiation to destroy or damage DNA of cancer cells. If we can focus a radiation beam, in a three-dimensional array on a tumor, and we can ionize the cancer cell's DNA so that when they try to divide, when they go through a mitosis, the chromosomes cannot break apart and the cell will go through a programmed cell death called apoptosis. So we use ionizing radiation to help patients who have cancer. We may treat them definitively. We may treat them post-operatively if they have a surgical resection and we're concerned that there might be microscopic cells in areas that have spread. We can treat those areas sort of prophylactically to prevent a recurrence. And that's basically what we do.
Okay. And why do some patients require radiation therapy while others don't?
Well, in the body we can make probably several hundred types of cancers, depending on the site of the cancer, the organ where it starts from. For example, lung cancer, there are 4 major types of lung cancer. If we talk about lymphomas, for example, which are tumors of lymph nodes, there's Hodgkin's lymphoma and there's non-Hodgkin's lymphoma. Within Hodgkin's lymphoma, there are 4 types. With non-Hodgkin's, there's like 10 types. So there are so many different types of cancers. And how we treat each one is very individualized. The patient may require surgery alone or radiation alone, or sometimes we do a combination of chemo and radiation therapy or surgery and radiation. So every type of cancer has a different protocol or a paradigm for the best way of treating that specific cancer. What we do is we'll consult with the patient. If the patient has a diagnosis of cancer, we'll meet with them, and then we'll talk about how and if radiation oncology will play into their overall choreographed procedure on how to treat them. So each one is individual. Some patients, for example, maybe really should have surgery, but their condition won't tolerate surgery, so then we may decide to use radiation.
I see. And what are some long-term effects of radiation therapy on cancer survivors?
That is a great question. So everyone we treat, we have to worry about not just curing them, but we don't want to cause problems down the line because of the radiation. As you know, and as we learned from Hiroshima and Nagasaki and Chernobyl and 3 Mile Island and all those nuclear catastrophes, that when people are exposed to low doses of radiation, the cells actually, the radiation may cause a mutation in the cell, one that doesn't kill the cell, but one that can turn it into a cancer. So we worry that when we treat someone, we may be curing their cancer, but there is a very small risk. It's about 0.1%, and it takes about 20 years to form a radiation-induced cancer. But that's why when we target, we try to minimize the amount of normal tissue that's seeing any kind of low-dose radiation. So we worry about long-term effects, particularly when we treat children. Mm-hmm. We worry that we don't want them to develop a cancer 20 years down the line when they're in childbearing years. We worry about scar tissue. So sometimes the radiation can cause some normal cell dropout, and those cells can scar and fibrose. So if we're treating a lung cancer, for example, the normal lung around the tumor may get radiation and it may get scarred down. And if that patient has bad lung function, they may find that they're coughing more or it's harder to breathe. So we have to worry about all the normal tissues that get any kind of radiation within the beams.
Okay. And how have radiation therapy techniques evolved over time? And what have you seen different from when you first started, working in this field versus now?
That's a great question. Computers have really driven our field into the 21st century. We used to do what we call two-dimensional planning. We would map out the patient, and then we would get a dose distribution in one plane. It was two-dimensional. Then with computers, we can now reconstruct the tumor on multiple slices of a CAT scan. I can target the tumor. The computer will do a three-dimensional reconstruction. And then we can shape the beam with 120 little fingers of lead that shape the beam exactly in the shape of the target as the beam rotates around the patient. So we can get a very tightly conformal dose around a tumor. The imaging has gotten so much better. Instead of not just 3D, we can now track a tumor in 4 dimensions, not only the 3D, but in time. So if a tumor moves in time, we can track that and shape the beam to accommodate, let's say for a lung cancer, while the patient is breathing, the tumor is moving. So we can track the tumor so that the beam is only hitting that. So it's a 4-dimensional plan. Our imaging is so much better. And because of our better imaging and our better computer planning, we can get higher doses into the patient, which translates into a higher cure rate. So I've seen the cure rate increase dramatically. We've seen toxicities go down dramatically. And that's really some of the important innovations. Now, with AI, we now have technology where the artificial intelligence can identify little tumor spots that we ordinarily wouldn't see with our own eyes. And it can alert us that, oh, there's an area that really needs attention. It can also auto contour. So if I'm worried, let's say, about the spinal cord when I'm treating, and I don't want to injure the spinal cord, the AI can contour the spinal cord for me in much less time than it takes me on each individual slice. The AI knows exactly where the organs are. It knows how to contour it and to do a three-dimensional reconstruction. So there's really been a dramatic proliferation in how rapidly we can come up with plans. We also have something called adaptive planning. So as the tumor shrinks, the computer can change the plan to accommodate the tumor shrinking over time.
Very interesting. And is there a genetic component to cancer risk? Are certain cancers more likely to appear during, any specific age groups?
Well, it's two questions. The first question, is there a genetic component? I mean, there are some cancers which are clearly environmental, like lung cancer and smoking, exposure to radon or other environmental carcinogens. But there are some cancers that do have a genetic link. For example, breast cancer, there's a genetic mutation called the BRCA gene, BRCA, which confers a higher risk of breast cancer, prostate cancer in men, pancreatic cancer, melanoma. And so there are certain genetic autosomal dominant mutations that can be passed from family to family. There's something like familial polyposis, which confers a higher risk of colorectal cancer. So there are some cancers like breast, prostate, which may have a genetic component. They may not, but there's definitely, when we see family histories that have a lot of similar cancers, then we start looking at the genetic makeup, and we can do genetic analysis, which is important for them and for their offspring. Now, in terms of are there certain cancers that hit different age groups? There definitely are. I mean, almost all cancers have sort of like a general modal distribution. Prostate cancer we typically see in older men. Breast cancer we also see as women age. But I've seen a trend in the last few years of younger women getting breast cancer. And it has to be environmentally related to all the plastics and the air that we breathe and the water that we drink. Hodgkin's disease, for example, has a predilection to hit teenagers and people in their 20s, for example. Testicular cancer also tends to hit men in their 20s. But there are other cancers which would be very unusual to see in that younger age group. We tend to see, more in older groups. Doesn't mean that it's restricted to those age groups, just that we see a predominant distribution in certain ages.
I see that you've mentioned that now you see a trend of younger women getting breast cancer. So what do you think could be a cause for this?
I want to say cell phones, but it's not. Twitter and all that. I think it's the preservatives, the microplastics that we find now in fish and in the oceans and vegetables and pesticides. I'm not really sure, but because breast cancer is hormonally mediated, and we see the age of menarche, which means the age when you first start to get your period, we see that moving down. It's like every decade it moves down a year. And we know that the earlier onset of menarche is associated with a higher risk of breast cancer. It's longer estrogen exposure to the developing breasts. And so all of these things that we ingest affect our hormonal balance and may be shifting menarche to an earlier age.
That's really interesting. And what are some early warning signs that a patient might need radiation therapy or further oncology evaluation?
Well, the patient needs to have been diagnosed with cancer before we even start talking about radiation. In terms of, does someone need to be evaluated for cancer? We look at sort of constitutional symptoms. Is their appetite good? Is their weight stable? If people are losing weight unexplained, I mean, if you're on a diet and you lose weight, that's great. But if you're not trying to lose weight and you can't put on weight, then that might be a trigger for, is there something going on in the GI system? If someone develops a cough, now we all develop coughs, we have upper respiratory infections, they go away. If the cough doesn't get better, if they start becoming short of breath, these are indications. If you have a mole or you have a new lesion on your skin and it's not a pimple, it doesn't go away, then we want to see a dermatologist. So anything that's, I don't want to say anything that's new and different, but anything that's new, different, and persists, you may want to have that looked at.
Okay. And how do you determine whether a patient's cancer requires radiation therapy or it can be managed with less invasive methods?
Well, I like to think that radiation is a less invasive method. It's less invasive than surgery, which requires an operation, anesthesia, several weeks of recovery. Radiation, you get every day, Monday through Friday, 5 days a week for a certain period of time. So I think radiation is less invasive than surgery. It's certainly less invasive than chemotherapy, which is exposing the entire body to toxic chemicals. Radiation is highly focused, so it's fairly non-invasive. But again, we have to determine what type of cancer the patient has, what is the best way of treating it, and if in that paradigm radiation is part of it, then we're going to move the patient into the radiation realm. We go through a simulation, which is sort of a planning process where we map out, we immobilize the patient so that they're always in the same position each day. We'll give them a few little tattoo dots on their skin so we can line them up with light lasers so they're always straight, immobilized, and then we'll do the planning for them. And then they go through their daily treatments, Monday through Friday. Usually takes about 5 or 10 minutes. The biggest issue is just getting to a facility and back. Mm-hmm. You don't feel radiation. There's really no nausea. There's no hair loss like chemotherapy, unless, of course, we're treating the scalp, then we might lose the hair. And if we're treating the stomach, you might get nauseated. But if we were treating a lung, for example, you're not going to have nausea from the radiation.
Okay, I see. And what habits should individuals establish to support their overall cancer prevention and treatment?
Okay. Very important. Number one, don't smoke. It is the worst thing that you could do. And I mean smoking, chewing tobacco, vaping. It is the worst thing that you can do for your health. And it may feel good and you may feel cool and more comfortable, but 10, 15, 20 years down the line, you're going to suffer. And it's not just lung cancer that's associated with smoking. Many types of cancers throughout the body. That's number one. Sunscreen. Very important to have sunscreen. And to go see a dermatologist on a regular basis. Skin cancer, we just talked about lung cancer. A normal, healthy, balanced diet. High in fruits and vegetables, low in red fatty meats, sort of a Mediterranean diet. Exercise and sleep. So, if you think about the three basic things, eating, sleeping, and exercise. You maintain a healthy balance with all of those and do regular checkups, skin, sunscreen, don't smoke, don't drink to excess, and then start screening for certain of the more prevalent cancers in women, annual mammograms from age 40, well, actually 50, but 40 if there's a family history, colorectal cancer screening with colonoscopies or Cologuard. So I would say if you want to modify your behavior to maximize your health, don't smoke, eat the right foods, maintain a healthy weight in terms of the muscle-fat ratio, exercise, sleep, and be happy.
Simply put. And can you explain the importance of proper self-care and follow-up during radiation therapy?
Well, when someone's getting radiation, the tumor cells are dying. The normal cells repair the small amounts of radiation damage each day. Cancer cells don't repair the damage each day. So the damage in the cancer cell accumulates each day. The normal cells repair themselves. For the normal cells to repair, they take energy. They use those ATP molecules that you learn about in biology, and they repair the DNA, they repair the cell, and that takes the energy from other areas. So we find that people do get fatigued during radiation, so they have to get a lot of rest. They have to maintain a good protein caloric intake. We don't want them to have a negative caloric balance. We don't want them to gain weight either, but we don't want them to lose weight during radiation. They have to maintain normal health, just the same parameters that we were talking about. Exercise helps patients get through radiation. They experience less fatigue. Eating well, maintaining a good fluid intake, maintaining good hydration. These are all very important self-help methods when people are getting radiation.
Okay. And can untreated cancer symptoms lead to more serious health complications if left unchecked?
Well, yes. I mean, we stage every cancer on a scale from 1 to 4. 1 is the earliest stage, 4 is the most advanced stage. The more curable the cancer is, the earlier the stage that we pick it up. That's why we do screening for breast cancer. We do screening for prostate cancer. The earlier we pick up a cancer, the more likely the patient will be cured and the less intense will be the therapy. So if you ignore symptoms, we see what's called stage migration. Instead of being diagnosed in stage 1, you may be diagnosed in stage 2 or stage 3 or incurable stage 4. And so ignoring symptoms only makes it less likely that you'll be cured and more likely that you'll need more intensive therapy.
Okay. And can factors like stress or anxiety affect the effectiveness of cancer treatment?
Well, we know that your general well-being affects your immune system. It affects the adrenal glands. When you're stressed, your adrenal glands secrete a lot of cortisol. Cortisol inhibits white blood cells. So when you're stressed, you can't fight infection as well. Your sleep patterns are off. And all these factors do play into our ability to fight cancer. If your body is stressed and making a lot of cortisol and you get an infection, you're less likely to overcome that infection. And when you have cancer therapy and your white blood cell counts are down because of chemotherapy, it can really be a catastrophic event. So very important to maintain your normal health parameters while you're getting radiation or chemotherapy.
Okay. And how can patients protect their health and manage side effects during cancer treatment? And can you explain the significance of checking up even after treatment, like to avoid things like relapse?
Yeah, well, we have to, we follow patients very carefully for many years sometimes. And depending on the cancer, some cancers are more likely to recur in the first year, some in the second. So we follow patients. They need physical exams periodically to see if there are new lumps or bumps. We do blood work on regular follow-up. Some tumors secrete certain proteins that we can measure as markers, like prostate cancer. We'll make something called PSA, prostate-specific antigen, which is a glycoprotein that sits on the prostate cancer cell. And we can detect an early recurrence if we see the PSA starting to rise. So the earlier we get these recurrences, the better. So we follow people with blood work, sometimes with CAT scans or MRIs, and physical exam. Very important, because if we can monitor and find a recurrence early, we can often cure it a second time.
Okay, and how has the COVID-19 pandemic impacted cancer treatment and patient care practices?
Well, a couple ways. That's a great question. The first was people didn't go to their doctor during COVID. They didn't get screening mammograms. They didn't get routine blood work. They didn't have colonoscopies. So we did see after the pandemic, and although we're still sort of in an epidemic type of fashion, people aren't dying in the same way. We saw a stage migration. So in the year or two after, like in 2022, 23, 24, we see people presenting with more advanced cancer than they did. In the heart of the pandemic, we tried to get people through their treatment as quickly as possible. So instead of giving them smaller amounts of radiation, sometimes we gave them a little bit more each day. They didn't have to come for 6 weeks. Instead, they came for 4 weeks. Because every time they came into our office, they exposed us and we exposed them. If someone came with COVID, we had to treat them. They had cancer, so we would treat them at the end of the day. We would do a terminal clean at the end with spacesuits and clean the table, clean everything that they came in contact with. So it was a very stressful time. We're treating cancer patients who have COVID. They have 2 potentially lethal cancers. Very, very difficult.
Okay. And what is the significance of following preventative measures and safety protocols, even if you have not been diagnosed with cancer?
Well, let me see. Safety protocols. You can create your own safety by doing some of the, or avoiding some of the things that we talked about: smoking, excessive drinking, putting sunscreen on, getting plenty of rest, wearing a seatbelt, things like that. Now, that doesn't affect your cancer risk. It affects your overall health. I think it's never too early to start taking care of your body, to start thinking about how you want to be. And now this sounds old to you, but it sounds young to me. But how do you want to be when you're 40, when you're 50, when you're 60? You want to be active. Do you want to have good muscle and bone strength? Do you want to be sedentary and overweight? Because, if you're going to live into your 80s and 90s and even, for a century, you want them to be good years. So you should always practice safe measures. You know what I just thought of? Getting the HPV vaccine. Very important for you youngsters, and I hope everyone did. We didn't have the HPV vaccine when I was growing up, but very important to get that. That is a very, very good cancer preventive activity. Get the HPV vaccine.
Okay. And can hormonal changes impact the progress of cancer treatment or the risk of recurrence?
Hormonal. Well, stress, lack of sleep, that does affect our hormonal balance. As I mentioned, everything affects our hormones. Everything. I mean, the hormone system, the pituitary gland, the thyroid, the adrenal, the pancreas, all of these are so closely interactive that if one is off balance, another one easily gets off balance. And when the body's homeostatic mechanisms, when the hormones are out of balance, anything can happen. Our immune system helps protect against cancer. Why? Because the white blood cells that are circulating, they may see an early cancer cell that doesn't look like the other normal cells, and they see it as foreign, and they attack it and kill it. So we have cancer cells that are forming all the time in our body, all the time. We don't know it because our immune system recognizes those cells as abnormal, and they destroy it. If your immune system is out of whack because your hormones are wacky, because you're not getting sleep, you're stressed, then your immune surveillance, that's an important term, immune surveillance to destroy these early cancer cells, doesn't work.
Okay. And can you give us a briefing about a complicated case you might have had with a young individual?
How young?
Maybe 20s?
Well, okay, 22-year-old man who presents with a painless enlarged testicle. He's embarrassed to raise it to his family. He waits a few months till he goes to for his sports physical for school, college, and they notice this testicular mass. He has an ultrasound, and it looks like it's malignant. So they do an orchiectomy. They decide to take the testicle out. Now he's faced with one testicle, and he's going to need either chemotherapy or radiation therapy, and he wants to father children someday. He wants to have a family, and he may potentially not be able to. He may become sterile from the treatment. And so we'll counsel him on sperm banking, and what the benefits are and the risks. And he's got to give several samples before we start. So there's always a rush to get that done. And so here's this 22-year-old who's not really thinking about having a family when he's in his 30s, but he's got to start thinking about it now to plan so that if he does want to, he's going to be able to. And then when we treat him, we have to say, what are the risks of maintaining fertility? And that might modify how we treat him. Same in women, women who have issues, who present with, let's say, Hodgkin's disease. We worry about fertility, and we may want to move their ovaries to get out of the area where they're going to get radiation, if they're going to get radiation. It's called oophorectomy, so that we can protect those ovaries from being irradiated. All sorts of issues in young, not young people, but in kids in their 20s. You're not kids, you're adults. A lot of issues thinking down the line, particularly when you're in your 20s and 30s. Less so when you're in your 50s, 60s. We don't worry about procreation as much. We worry less about secondary tumors.
Oh, that's very interesting because being diagnosed with, like these malignant, masses across the body at a young age, it can have, maybe severe consequences, like you said in the case of, this 22-year-old male. So how can, prevention avoid these consequences at such a young age? Because activities like mammograms, you usually don't do them until 50, as you've said. So how can we, prep from such a young age?
Well, a lot of people in their teens and early 20s don't think that they have to go to a doctor every year. I mean, they did when they were children. They needed their shots. Their parents had to check their growth. And, once you're sort of on your own, you're an adult at 18, you think that, I'm healthy. What do I have to go see a doctor for? But you do. You need to have a physical exam once a year. You don't necessarily need screening tests like mammograms, ultrasounds, but it's good to have a professional examine every year and draw routine blood work, CBC, a white blood cell count, a sugar, glucose level, chemistry level, liver function tests, kidney function tests, just to see if there's something that is awry. And if it's awry, then how do we pursue that? So I remember when I was going through college, I don't think I saw a doctor unless I felt sick. I didn't go for a routine physical until I was in medical school, and we learned how important it was to have regular checkups.
I think that was really relatable, even, back in your time. And now I think routine checkups is pretty, that's really important that you touched on that. Okay, so let's move on to the next segment of our interview, which includes common myths about radiation and general oncology.
Okay.
The first one, radiation therapy is very painful.
That's false. You don't feel radiation. We're getting irradiated every day. We're getting cosmic radiation from the sun. We don't feel it. We can see effects of inflammation caused by the radiation, but getting the treatment itself, there's absolutely no sensation at all. The skin can get red, just like a suntan or a sunburn. That can be irritative and painful, but that's not from the treatment. That's a side effect from excessive radiation.
Okay. You can only get radiation therapy if you have advanced cancer.
That's not true either. We treat very early cancers, laryngeal cancer, for example, tiny little vocal cord cancer, the T1, T2, we treat with radiation, it's gone. We have an extremely high cure rate. So very early cancers, skin cancers, if they're not going to remove it, I mean, rather than removing your voice box and talking with one of those electrolarynxes, radiation is very, very effective for early stage cancer.
Okay, so the third one, cancer is contagious.
Not at all. Not at all true. The only example for cancer to be contagious is if an identical twin had cancer, let's say a blood cancer like leukemia, and gave a transfusion to his or her identical twin sibling, where their immune system is identical, their cells are identical. That's the only way that you could contage one cancer to another. It is now something like HPV, human papillomavirus. The virus is contagious, and the virus can predispose to cervical cancer, oropharyngeal cancer, cancer of the throat. But the cancer itself isn't contagious.
I'd like to ask a question because you mentioned blood transfusion. So suppose we have a cancer patient who has finished treatment and I don't know if I would say free of cancer, but they've completed the treatment and they decide to give a blood transfusion to an individual who does not have history of cancer. So can that pose a risk of, cancer?
No, there's no way that blood transfusion could transmit cancer to another patient. I'm not sure that the blood bank would accept someone who's had previous cancer. I mean, yeah, that's usually one of the screening questions. Now, it may be that, you can have skin cancer, but if you've had a cancer of a viscera or an organ, they may just exclude you. I'm not sure. And that's not because it's risky. It's because of this psychological worry that people who had cancer are giving you blood, but there's no way that you can pass it on.
Okay. Only smokers get lung cancer.
20% of lung cancer is in non-smokers. It's not true. There's other risks. First of all, there's secondary smoke, passive smoking, which hopefully is, nearly outlawed these days. But some people who don't have any risk factors can develop lung cancer. We live in the United States. We're breathing the air of New Jersey. So, not true.
Okay. And the last myth, there are not a lot of treatments for cancer.
Also not true. There's surgery, there's chemotherapy, there's radiation therapy, there's immunotherapy, there's targeted therapies where we find what kind of driving DNA mechanism is causing that cell to proliferate. We can block those with certain blocking agents, targeted therapies. There's photodynamic therapy, light laser therapy. There's so many options. The best one is very dependent on which type of cancer you have and where it is.
Okay, this one I found interesting because I think when you mention treatments for cancer, many people might think about chemotherapy or surgery at first.
And sometimes that's the case. Sometimes you want to get the tumor out, then you want to give chemotherapy to kill any microscopic cells that have floated through the body. But depending on the cancer, how well it's differentiated, how it looks under the microscope, sometimes we look at the genetic fingerprint of that cancer to get an idea. Like in breast cancer, there's something called the Oncotype DX, which gives us a comparative risk, the genetic fingerprint of that particular cancer and its risk for spread. And that might determine whether or not the woman gets chemotherapy. So it's very much dependent on the individual, their tumor type.
Okay, and now we've reached our final questions. So we'll start with the scenario case. Suppose a teenager with a family history of cancer is considering to join in school sports or a school sports team and is concerned about the impact of physical activity on their overall health. How can participating in regular exercise contribute to cancer prevention and overall well-being?
Well, regular exercise, being on a sports team, is going to maintain lean muscle mass. It's going to maintain a good muscle to fat ratio in the body. Exercise is great in terms of your ability to actually then sleep. So when you burn off all of your excess energy during doing physical activity, you're able to sleep better. So all that leads to better health, because when we maintain a good immune system, when we relieve stress through exercise, we have better auto surveillance of cancer cells in our body. So I strongly encourage people to either be on a sports team, as it was, and if not, then just to maintain regular exercise. Make it a part of your daily life.
Okay. And what is your take on Google Doctors?
You mean people who Google all their medical questions?
Yes.
It worries me. I don't know who puts in the information for Google Doctor. I think you can get a lot of information that's helpful, but you can get a lot of information that is useless and actually harmful through Google Doctor. So I do, just like anything that you Google, you're going to get good information and bad information. It's hard to know when you're not a medical person or have expertise in the field, like what's real and what's not. And there's so much garbage out there. So I'm not a fan of Dr. Google. I'm a fan of people who have gone to medical school or osteopathic school, or nurses, or nurse practitioners. Those are people to really contact. Now, you can look up, there are some very reliable websites. You usually have to pay a subscription fee to get on them. One of them that I love is called Up to Date. It's for physicians. But I mean, if I have a question about a certain condition, I go to Up to Date, and there's literature that's explained, and you can. So those kind of refereed websites, I think, are very valuable. But Google, it's good for a search engine if you're looking for, you want to buy something, not in terms of health.
I agree. Okay, so our podcast session has now been completed. I want to thank you for your time, insights, and contribution. For our listeners,
nourish your habits to flourish your lifestyles.
And don't forget to follow us on our website, healthyteens.net, and stay tuned for the next episode. Take care.